Hello students, welcome to the class on blood transfusions, best practice guidelines. Today we are going to learn about transfusing red blood cells and what the guidelines to administering and assessing reactions are. Okay, so let's start with some basic information about blood. Every 2 seconds, someone in the US needs blood. Approximately 21 million blood products are transfused each year. Blood and platelets cannot be manufactured. They can only come from donors. There are so many reasons red blood cells will be administered to your patients. Some of the reasons include treatment for symptomatic anemia, life-threatening anemia, to restore oxygen carrying capacity in hemorrhage, a hemoglobin of less than 7 in hospitalized hemodynamic stable adult patients, a hemoglobin of less than 8 in patients having orthopedic surgery, cardiac surgery, or pre-existing cardiovascular disease. While these specific cases call for giving red blood cells, some call for exchanging the blood. These instances include specific cases such as sickle cell disease, parasitic infections, and hyperbilirubinemia of a newborn. In these instances, blood is removed from the patient and replaced with donor blood in order to create homeostasis. As a minister of blood, it is important that you understand how to administer blood to a patient in a safe and consistent manner. Oftentimes, if your patient is in need of blood, it may be the case they are very sick or even nearing death. It is your duty to act appropriately and swiftly to help the patient. As always, you must follow your facility's specific protocols when it comes to blood. However, these are the best practice guidelines. Pre-transfusion necessities include assessing vital signs, including blood pressure, temperature, pulse, respiratory rate, and lung sounds. The patient will also receive a type and cross-match per facility protocol. For example, at our hospital, we do them every 3 days as needed. After the blood is procured through the lab, with a dual check at the lab, it is important that they have a dual sign-off and cross-check with the charge nurse at the patient's bedside. They will check the patient's date of birth, their name, and the blood with the patient specifics. After all the checks are complete, the primary nurse will then remain with the patient throughout the first 15 minutes of the transfusion. This is important. People can have transfusion reactions within the first 5 mLs of blood. Infusing 25 to 30 mLs total to the patient in those 15 minutes will make sure that they are not having a transfusion reaction or is quickly assessed by the nurse. The patient is then reassessed by the charge nurse and the primary nurse for transfusion reactions. If it is agreed that there are not any signs of reaction, the blood may be continued to be administered at the higher rate as tolerable by the patient. Again, you want to make sure you're reassessing the patient as you are doing this. Even if they did fine in the first 15 minutes, they could have a delay reaction. There are many different transfusion reactions that could happen to your patient, but generally, you're looking for changes in your patient, including vital sign changes, hives, itching, fever, and/or chills, hypotension, and dyspnea. Patients may present differently based on reaction they are having, and treatment is also tailored to the type of the reaction they are having. The types of reactions include acute hemolytic reaction, acute lung injury, air embolism, anaphylaxis, bacterial contamination, febrile non-hemolytic reaction, hypothermia, metabolic abnormalities, a mild allergic reaction, and volume overload. We will discuss these different type of reactions and treatments as we move more into the class. Everything you need to know to give blood to your patient will be discussed in this class and any questions you have answered. I look forward to teaching you all about blood transfusion guidelines. I hope you enjoy the class.